right, welcome everyone to round today. I'm really excited. We've got Shehzad today as a speaker, and I didn't know you, which is kind of weird because you're working in the same field and all the work looks like really interesting. So Shehzad is just in Toronto, been for 2 months working with CADIS, brand new. He's also visiting associate professor at the University of York in the UK. He has a broad background in health economics, statistics, public health, and of course, clinical medicine. So you're a physician by training. A lot of experience as an academic researcher and consultant in the public and private sector. He has had a lot of grant funding in the UK and in the US and in Australia, all around the world. And his research interests are in HTA, looking at diagnostic and treatment strategies, doing modeling, also looking at treatment effects of interventions using real-world evidence, which many of us are doing as well, looking at monitoring and benchmarking health service performance in terms of efficiency and equity of access, utilization, and outcomes, using big data or large health administrative data sets. Also explaining heterogeneity in health outcomes and predicting events using individual patient-level data, and looking at eliciting value judgments and for treatment preferences to inform resource allocation decisions. So a lot of different things. So I'm really excited you're going to talk today about health equity. It's something that I'm personally really interested in, and I know a couple of people in the room are really interested in health equity and how we I guess our interest is how we possibly could include that in economic evaluations and kind of extend economic evaluations to include health equity. And I think which we just really quite do yet or not enough. So I'm very much looking forward to your talk. But before you can start, we go around the room as always, introduce ourselves. So I'm Alexander. I'm a scientist here at THETA and associate professor at the University of Toronto.
Hi, I'm Joanna Bielewski. I'm a research librarian here, and today I'm moderator for our 15 SMDs online.
I'm George Tomlinson. I'm a biostatistician here at UHN and a senior scientist in the Research Institute.
Okay. I'm Suzanne Chung. I'm a research associate here at THETA.
Alex Haynes. I'm a health economist here at THETA. Hi, I'm Afro Shimeni. I'm full doctor. Okay.
I'm Panasha. I'm a master's student at Honest School.
I'm Rafael, and I'm working here at THETA as a volunteer.
Okay. I am Luciana Breman. I'm an assistant professor at University of Toronto. I also do some work with CADIS.
Okay.
I'm Lauren, a PhD student at THETA.
I'm Aisha. I'm a PhD student here at THETA.
Okay.
I'm Troy Francis, research associate at THETA.
Okay.
Great. Over to you, and questions at the end, unless it's a burning question and we don't know where it's going. Don't understand.
Okay.
That's it.
Yes.
Yeah. All right.
Right. Hello. I'm very excited to be here. I've just moved to Canada, as you said in the introduction. The British weather was not working for me, so I just wanted to experience proper winter. So here I am. Right. So. As I say, I have a visiting position now at York. I'm fully here. This work was carried out during my time at the University of York, and I'll mention about contributions of other authors. So the thing that I'm going to talk about is health equity, particularly in relation to monitoring performance and confronting trade-offs. And this is an area that has been very active in research in the last few years. We have certainly done some work in this area because we find it very exciting. So this is the core team: Richard Cookson, myself, Mikdad Asaria, all based in York. Aki Soshia was involved in the trade-off studies, and she's based in Sheffield. So funding came from UK and IHR, and we published a few papers which are listed here. So they should all be available online, except for the first one, which has recently been accepted, so we're just getting the minor tweaks done, and it'll be available online soon. So before I start talking about health equity, I just want to briefly mention about my own research interests. I'm particularly interested. The first area of my research interest is identifying effective and cost-effective interventions And when I say interventions, I mean micro-level interventions which are delivered at patient level, such as drugs, or meso-level interventions, interventions that are delivered at provider level, so looking at developing algorithms that can provide feedback to therapists to improve patient outcomes. So that's one of the studies that we recently did. I'm also interested in macro-level interventions, so health policy interventions, such as health financing interventions, early childhood obesity interventions. So at different levels, I'm also interested in measuring performance of health services, which is an area that I'll talk a lot about today. There's two cross-cutting themes that I'm particularly interested in. I'm very much interested in methodological challenges and addressing those methodological challenges in when you're doing research in these two areas. And the other cross-cutting theme that I'm very interested in is equity, which is what I'll be talking about today. So the motivation for the work in health equity is that we know the economic problem is that resources are scarce and decision makers need to make decisions about allocation of resources within fixed budgets. We don't have unlimited resources. We want to make use of the available resources. One of the most commonly used approaches for resource allocation is cost effectiveness analysis. And as we know, we try to do the most good that we can, and good is a term that can be defined in different ways, using fixed budget. However, we know cost effectiveness analysis is much of effectiveness study, effectiveness literature that is out there. It focuses primarily on averages. And cost effectiveness analysis, conventional cost effectiveness analysis, has nothing to say about the distribution of health benefits. So this is an area that has largely been ignored. There is literature out there. There are studies that have looked at distribution of effects or health benefits, but it's not the mainstream of literature that we see. And we know averages high distribution. If you are implementing a program, there are winners and losers. There are people who gain, there are people who lose out. There are people who gain much more than others. Resources need to be moved from one place to another. So there are, fundamentally, there are winners and losers of a program, but we often lose that picture by focusing on averages. Now, equity is a normative concept. In economics, we often sort of look at equity, inequalities in terms of variation or differences. But equity does not always imply equality. We don't want to equalize things, as it's nicely presented in this picture. But equity refers to fairness. It's a value judgment. What is fair in one society may not be fair in another society. What is fair in the present time may not be fair in 20 years' time. So these are value judgments that we need to elicit. Also, it's important to understand that value judgments can come from philosophical studies or philosophers, but a huge part of literature that is growing, especially in the last few years, is focusing on empirical value judgment. So asking people what they think, using people's value judgments to inform decision making. So all of that is part of driving an agenda which focuses on equity-based value judgments, equity-based decision making. So there are different dimensions of equity. You may be interested in income-related equity. You may be interested in gender, age. There are different aspects. The literature tells us that the key elements that people are generally interested in, based on value elicitation exercises that have been done in the past, the three areas that have come out consistently as a high priority for the general public are severity of illness. Now, in the economic literature, we often talk about allocating resources based on need, and need is generally defined in terms of capacity to benefit. It's not defined based on severity of illness. So the condition that I have may be more severe than yours, but if I can't benefit from the treatment, then my need in economic terms is lower than someone else who can benefit more from the existing technology that is available. But some of these studies have shown that severity of illness, irrespective of your capacity to benefit, is an area that people think should be taken into account when you are talking about resource allocation. Children versus adults, no surprises there. People prefer to allocate more resources towards treating conditions that are more prevalent in children. Socioeconomic inequality is an area that has been researched extensively, and there is general consensus that people do care about socioeconomic inequality. So this is an area that I will focus on, and the focus of this talk is to demonstrate methods, provide a framework, but the same principle can be used if you are interested in inequalities in other areas. I've been told that there are sort of different groups in Canada who may be considered marginalized. So you may be interested in inequalities, particularly in relation to those groups. So the same framework can be used and extended. Now I'll mainly use data from England because this work was carried out in England, but I think most of this could be translated, you will appreciate the context. It's very similar to the Canadian context, apart from the fact that Canada is about 100 times, I didn't know this, about 100 times the size of England, and your population is pretty much half the size of the UK, the population size of the UK, but England is about 50 million people. But yeah, so the geographies are different, but the context is very similar. So if we divide the population of England into 5 groups, then we've got the 5 quintile, the poorest, each quintile with about 10 million people. And if you look at the household income, the poorest quintile, on average, their household income is roughly about £15,000 a year. And the richest fifth, their income is roughly in the region of 61,000. So there is a big gap in income, which we can see. But what is more surprising is that if you look at the expected years of life in full health experienced by people in the in the richest quintile compared to the poorest quintile, so it's basically talking about an idea of a quality adjusted life here. There is a gap of about 12 years. So the poorest people in poorest quintile experience 12 years less of life in full health. That is quite shocking to me, and I think that is one of the motivating factors for doing research in this area. Now, of course, you can't put all of that on the NHS, on the National Health Service. You can't say it is NHS's fault. A lot of it is pure luck, and a lot of it is based on individual choices, individual behavior. But a big component of this is due to social responsibility. It's kind of down to social responsibility as well. And then this is something that I'll demonstrate in some of the analysis that we have done. So equity has been highlighted as one of the key priorities in England and also in Canada. So I was looking at the Health Canada report on plans and priorities, the last one that came out recently last year. So they've highlighted equity as one of the major concerns, and it's an area that they want to focus on. And in the UK, the Health and Social Care Act that came out in 2012 has actually made it a duty for the NHS to reduce inequalities in access and in terms of outcomes. So based on that, I think it is very important that we think about incorporating health equity into decision making. So there are two areas that my research is focused on, and I think they are important, and other people have been working in this area as well. The first one is equity informative performance monitoring. So we monitor performance in terms of efficiency. We've been doing this for decades, but it's important to bring in equity into that framework of performance monitoring. And the second area that I'll talk about is equity informative economic evaluation. So these are obviously two major areas that health economists work in, and the focus of my talk is on bringing equity in the picture. So I'll keep an eye. Realize there's no clock here, so I'll just keep an eye on my phone just to keep a track. Right, so I'll start with equity informative performance monitoring. So when we started this project, we thought that there are a number of indicators that exist out there. What we need is a framework, that in which indicators can talk to each other, so they're not analyzed in isolation. So the consensus that we came to was to look at patient pathway. So patient pathway, we thought patients can be, or people generally, so they can be in the community, at home. They may seek primary care or community care, then they may require hospital admission or hospitalization of some kind, and they may die. So this is obviously a simple diagram, but we use this patient pathway to identify important indicators that we can use to measure performance of healthcare decision makers. So as you can see, there are a number of indicators that we've identified here, which so primary care supply, number one, and primary care quality. These are very important indicators, and again, they have been used particularly in relation to evaluating efficiency, but not so much looking at equity. So when you are in primary care, you may be referred to hospitals, then we are interested in looking at hospital waiting time, whether there are differences between areas, between regions, between provinces. In the context of Canada, you can think of provinces. In terms of waiting time, and England, we often talk about postcode lottery. So depending on where you live, you may have to wait longer for the same admission, right? And that may be associated with deprivation as well. If you're in hospital, so there are preventable causes of hospitalization, which I'll talk more about. Once you're discharged from hospital, you may need a repeat hospitalization for the same cause. The other thing is you may die in hospital, or you may die outside of hospital, and either way, the causes may be amenable to healthcare. So we've got the definitions here. I won't spend too much time talking about the indicators, but just to clarify what these definitions are. So when we are talking about primary care supply, so we in this particular context, we were interested in supply of general practitioners. Of course, you can look at supply of nurses and other health practitioners. So we were interested in patients per full-time equivalent primary care physician. What is their distribution? How many patients are they responsible for? Each GP, how many patients they are responsible for? Is that distribution the same between rich and poor areas? We were also interested in primary care quality. So in the UK, there has been probably the biggest, or one of the biggest pay for performance initiatives that's happened in the last couple of decades, or just over a decade, something called quality and outcomes framework. So in that framework, GPs have to collect certain data about their patients, and they have to report back that data. So that data set goes back a few years, and we've got this enormous data set that we can actually use to evaluate quality of care. So again, we were interested in evaluating whether there were differences between rich and poor areas. Hospital waiting time I've already talked about, so we define that as time between outpatient decision to treat to inpatient admissions for treatment. So that waiting, because obviously waiting time can be defined in different ways. Preventable hospitalization. Now, what is considered preventable? There is a lot of debate in the literature, and there's general consensus on a list of conditions for which you should not really need a hospital admission. So things like diabetes, that should be controlled, asthma, it should be managed in primary care. You should not really need expensive hospital admission for that. But if primary care is not working well, then it is likely that you will need an emergency admission for things like epilepsy or tuberculosis. There's a whole list of conditions which we have listed in our project report. The other one is repeat hospitalization. Again, now we're looking at inpatients with one or more subsequent any cause emergency admissions. So once you discharge, this is an indicator of how good the social care is, how good the primary care is, how good they are in communicating with each other, right? Once you're discharged from the hospital, how well you are looked after. And if the system is not working, you may need to come back for a repeat. But again, we are looking at emergency repeat hospitalizations, not sort of scheduled ones. Dying in hospital, that's an interesting indicator. So that is an indicator which sort of tells you how well your palliative care is planned, how good is the support available in the community for people who have terminal conditions. So this is an indicator, but the denominator here is the total number of deaths, and of that, what proportion of those deaths actually happen in hospital. And the final one is amenable mortality. So these are conditions for which you should not really see people dying from those conditions. Again, diabetes is one of the hypoglycemia. You should not really have people dying from those conditions which are preventable. And again, there is an agreed list which is based on the literature, and that list is available online. So I'll just briefly talk about the geography and deprivation. So England is divided into 32,000, about 33,000 actually, that number has just gone up. 32,000 small areas, or what we call lower layer super output areas, or LSOAs. And these are small areas with an average population of roughly about 15,000 people. Sorry, 1,500 people, sorry. There are small areas. So, and there is some variation around that, but this is the average figure. Then there are English large areas. These are the ones that we are particularly interested in because these are decision-making areas. So these are what we call clinical commissioning groups. There's 211 in the UK. You can I think the closest equivalent I can think of in the context of Canada are LHIN. I think yeah, so there's probably 10 or 11 of those so they're responsible for the health of certain population. So these are decision makers. They hold budgets. They are responsible for funding allocation decisions. So basically, each CCG has got is responsible for the health of a large number of LSOAs. So and that's what we are interested in. We're basically interested in how good is the performance of each CCG compared to other CCGs. Now, deprivation is obviously the fundamental thing in this, and there is the index of multiple deprivation, which has been used extensively in previous research, which basically looks at a number of domains. So for each LSOA or for each small area, we know what the deprivation level is, which is based on income, household, ownership, education. A number of domains are used. So these are commonly used in the literature. Now, we had access to a number of large data sets, and as a researcher, you can obviously apply for to get access to this. It's a painful process, takes a long time, and I'm sure it may be quicker in this. in Canada, but it takes a while to get access to data sets. But there are large data sets that exist, and they are linked together. So you've got primary health, primary care data set that is linked to hospital activity, and hospital data is linked to mortality data. So you can actually look at the whole pathway, which is very exciting. So what we were interested in is there's three things that we thought we would be interested to look at. The first one is equity performance. So we thought the first thing that we want to look at is the national performance. So as a country, England, how good is England doing in terms of tackling inequalities when we talk about these indicators? The second thing is, because a lot of, or most decisions are actually made at local level, we wanted to produce these indicators or performance measures at local level. So currently efficiency indicators are available at local level, but equity indicators are not. So we were very interested in sort of producing these indicators at local level. So you can go back to the decision maker and say, see, we've adjusted for a lot of things, legitimate confounding factors, and this is how your CCT is doing in terms of tackling inequality. So I'll present some results here. And so the first part was producing indicators. The second part we were interested in fact, actually, let me just talk about the indicators first, and then I'll talk about the second bit. So this is an example of a national level performance indicator. So preventable emergency admissions by deprivation. It's quite interesting to see that there is a huge gap between the richest and the poorest quintile. At the bottom, you have the richest quintile. So about 4 point something per 1,000 population, this many in a whole year, this many emergency admissions. Whereas the richest quintile on average, they've got much higher chance of emergency admission. So there is something going on. So we adjusted for age and sex and sort of legitimate confounders that we can think of. The slope index is basically just sort of, it basically comes straight from this, and anything that is on the positive axis basically suggests a pro-rich inequality. So rich people richer areas have got fewer emergency admissions compared to poor areas. Now, the next thing that we thought would be interesting, and we obviously produced these indicators for these graphs and everything for all the indicators, and again, all the details are available in either the papers or the report that we published. But we were also interested in evaluating interventions and policies. So we thought government obviously is aware of inequalities that exist, and they often put in place these policies. And we need to look at whether these policies are working, whether the intervention has had an impact. So we thought, because we're not producing these single-year cross-sectional indicators, we are producing effectively what we call equity movies. So we're basically looking longitudinally, starting from 2004-05, and as years of data become available, we can update these indicators. So these are equity movies, and we can use that to evaluate policy. So that's one of the things that we did here. So in the early sort of parts of 2000, there was an inequality that existed in terms of the distribution of GPs in the country. So the government was aware that GPs are probably less keen to work in crowded, poor areas that have got a huge level of deprivation, illnesses. Probably doctors are happier to sort of working in leafy suburbs. So the distribution is not equitable in that sense. So a huge amount of money was pumped in, and a large number of doctors were recruited to be based primarily in poor areas. So there was this equitable access to primary medical care into a policy that was introduced roughly around about sort of this kind of time. And then what we saw was there was, over a period of time, there was a reversal. of the distribution of GPs in the country. We can't confidently attribute the whole thing to this program. Obviously, there are lots of other things happening. But basically, what I'm trying to demonstrate here, and we published this paper, and that sort of it demonstrates the method. What we were trying to sort of convey is that we can use these equity indicators that are measured longitudinally to evaluate health policies, because we can't just have a policy and not evaluate it. We need these indicators to be able to say something about whether the policy has actually worked or not. Now, I'll just provide some brief description of the local level indicators that we have produced. So, as I said, a lot of decisions are actually made at local CCG level. So here I've got graphs from two CCGs, North Lincolnshire and Ashford. So what we have is the green line shows the inequality from least deprived to most deprived. So the dots here, each dot represents a small area. So a CCG, as I said, it's providing care, or is responsible for care, for providing care to a number of LSOAs. So each dot represents a number of an LSOA, and sizes are obviously in proportion to the size of the LSOA. So looking at preventable emergency admissions again, this is the level of inequality that we see in this particular CCG. And the dotted, and the dashed line presents the national gradient. And then we also identified similar areas, because I'm sure you present these data to decision makers, and they say, no, our area is very different compared to X, Y, and Z, or compared to London, because London is different from everywhere else in England. I'm sure it's the same with Toronto. Then we identified a number of characteristics, and based on those characteristics, sort of, deprivation level, population density, education, all those indicators, we matched CCGs, and we said, compared to your CCG, these are comparator CCGs, and this is their average gradient. Now we are sort of looking at like-for-like comparisons. And so here on the right, the CCG is doing worse than the national average, and the sort of similar areas, whereas Ashford is doing better. So it's a very sort of visual representation, and you can actually you can produce these indicators year on year, because these data, once the framework is available, these indicators can be updated. So we also produce these. We produce a number of sort of graphical tools. Caterpillar plots, I think some people find it very easy to see. And obviously, each line here is a CCG. So you basically say, this is your CCG, and these are good performing CCGs, and these are worse performing CCGs. And there's a very nice online tool that we produce, and then you can sort of, it's an interactive tool that you can use to compare different CCGs with each other. And of course, we got a lot of press because of that, like, Manchester CCG's dominant list of worst for health. When you are producing things like this, there is likely to be not just press, but there's a lot of attention. Some of it you don't necessarily want. We also produce these dashboards because we thought it would be interesting to sort of look at all the indicators together, and also look at the average performance. So this is kind of looking at the efficiency side of things. So average performance for your CCG, average for England, and then how your CCG compares with other CCGs on a spine plot. And then the overall trend in the last 2 years, how are the inequalities changing? And then we thought it would be useful for decision makers to look at the actual gap between the richest and the poorest areas in terms of absolute numbers, so we produce those numbers as well. So again, some of these differences are not statistically significant, some of them are. So, the Guardian headline, NHS success in tackling. So what we managed to do at the end of this was get the NHS to adopt one of our indicators in their routine practice, so in their routine monitoring practice, which in terms of impact, we, as researchers, we need to demonstrate impact. That was quite an impactful story to demonstrate. Right. So that's the first part of the talk, or sort of the first bit that I wanted to cover. Now I'll talk about the second part, which again sort of focuses on the same idea that we need to bring equity into decision making. And the other big area is economic evaluation, which I'm sure a lot of you are involved in. So in economic evaluation, again, we generally look at cost effectiveness of conditions. We produce these nice cost effectiveness planes and CX and all that. And we thought it would be useful to look at a health equity impact plane where cost effectiveness is on the vertical axis and the equity impact is on the x-axis. So you may have a win-win situation where an intervention is cost effective as well as has a positive impact on equity, but you may have win-lose and lose-win sort of situations. And that's where trade-offs are required, and a lot of interventions actually fall into that category. So one of the examples that I'll mention briefly later is a bowel cancer screening program. So if you send letters out asking people to come for bowel cancer, what we know from the literature is that the uptake rate is different depending on the socioeconomic group that you belong to. So richer people are more likely to take up screening, but there are other interventions that are available which can potentially improve uptake rate in poorer areas or among the poorest fifth, but they tend to be more expensive. So an intervention such as writing personalized letters from the GP, they tend to have a bigger impact. So people are more likely to turn up and take on screening for bowel cancer if you write personalized letters for them. But they're obviously more expensive. They're more time consuming. So there are trade-offs involved in any intervention. For smoking cessation, again, there is a gradient. We know that the same intervention does not work. It's harder in some poorer areas to get people to give up smoking. So some of the interventions cost more. They may have lower impact. So inevitably, some trade-offs are involved. So moving on. So it's all well and good. So there is a lot of talk about bringing equity into decision making, particularly in relation to economic evaluation. So you may have come across distributional cost effectiveness analysis, which some of our colleagues in York developed. There is other frameworks such as extended cost effectiveness analysis. And most studies actually rely on some sort of value judgment. So distributional cost effectiveness analysis certainly relies on value judgment, social value judgment. What sort of weight do you want to put on inequality aversion? So, and that is something that we need to elicit from general public. And that is not an easy exercise at all, as I will demonstrate in this part of my talk. So there are sort of, questionnaire methods that are available, there's a few studies that are available. So what we did was, based on some of the previous studies, we used a questionnaire that has been used quite a bit. So we basically show people the distribution, the initial distribution. You say, in England, 62 years of for life and full health experienced by people in the poorest fifth and 74 years in the richest fifth, which we said earlier. Now, how about this? Consider two programs, Program A and Program B. And these programs will benefit the richest and the poorest fifth differently. So Program A gives 7 years of life in full health, additional 7 years of life in full health per person to the richest fifth, and 3 years of life in full health to the poorest fifth. And Program B gives you exactly the opposite. So in terms of efficiency, we're still getting 10 years of life, but the distribution is obviously different. And we obviously make it clear that you need to choose between the two programs, and we can't pay for both programs. If you say they're equally good, you mean that you're indifferent between the two programs. And both programs cost exactly the same. The only difference between the two programs is who gains what. And we also make the assumption, to simplify things, that the middle fifth is not affected. And still, we have simplified this exercise quite a bit, but it's not an easy exercise. So this is how we presented the information. So what happens after you've gained 7 years? The richest fifth will get 81 years, poorest fifth will get 65 years in program A, and the distribution is different in program B. So there's a number of things that are happening here. The sum total, 10 years in both programs. The outcome after you have given these additional years, and also the gap between the richest and the poorest fifth. So richest and poor, the gap here in program A is 16 years, whereas it's down to 8 years in program B. So there is a number of things that you need to consider. Then we said, now imagine it is more difficult than we initially expected to benefit the poor. So actually in program B, we won't get 10 years. So the poorest fifth will still gain more, but they'll get 6 years of life rather than 7. So the sum total is 9 in program B versus program A being 10. And we kept everything the same. The only thing that we changed was the benefit to the poorest fifth in program B. So this is the only thing that we changed. This is the last bar. And then we sort of kept reducing it, and then we asked people, which program do you prefer? And then this was the final choice, where the two programs, program A, effectively a dominant choice, in inverted commas, because the poorest fifths are not gaining any more, right? If you chose program B, but in terms of efficiency, you are getting a lot more in program A. But if you look at the gap, is 16 years in program A, and it's much smaller, 12 years in program B, right? So different ways. So we basically said, okay, now based on this, we classified the responses into effectively 5 groups. So if you choose program A to start with, the benefits are the same. You're pro-rich. You want rich to get more, even more, because in terms of efficiency, you're not getting any more, right? Health maximizer will choose equal AAA. So they would say, well, in the first option, they're equally good, right? We're getting maximum health for both of them, about the same amount of health, right? They're equally good. We don't care about the distribution of health. They're equally good for me. And then they will move to A, because A always gives you more. And then weighted prioritarians are the ones who give priority to the poor, but it's a weighted priority. It's not an absolute priority. They don't choose the poorest fifth always. They give some level of priority to them. And then what we have is maximin, the people who want to maximize the minimum, maximize the poorest, right? And they will basically choose B all the way up until it gets to the last set, where they say they are equally good, right? And then you have strict egalitarians who say program B is still preferable because it reduces inequalities, right? So interestingly, what we found was only 2% of our respondents actually preferred, were actually health maximizers, which is what we do. That is traditional cost effectiveness analysis. A collie is a collie. We don't care who gets it, right? It was interesting, quite shocking for us. 84% of people were willing to sacrifice some health for more equal distribution. Now, of course, you would say these questionnaires are full of framing effects, cognitive biases, and all that. So I'll just talk. I'm sort of conscious of time, but I'll present 2 experimental studies that we did as fast as I can. So we still need hopefully some time for questions. So I'll come to study one, which basically looked at different ways of framing the same question, right? Now, we know, for example, that giving 7 years of life on average to each person, that is never going to happen. There's no program in the world that will give, on average, 7 years of life, additional life to each person in the population. What happens in reality is some people will gain a few months or a few years, other people will gain nothing, right? On average, it works out, probably if you look at the whole population, it sort of works out a few hours on average per person. So what we thought was, let's make it more realistic, like keep the same ratio, present the same information in a different way. So we said, large gains is the one that I presented earlier. Small gains present the same information, but in hours, right? Small gains abstract at population level. So we said, okay, there may be a framing effect in terms of when we present information at individual level. So when you say 7 hours per person, that doesn't sound much, right? What if we say 7,000 years for the richest fifth and 7,000 years for the poorest fifth, which is roughly about 7 hours per person, but we didn't give that information. Luckily, nobody figured that out, at least nobody said that they did. And then we said, okay, we've been talking about a lot of abstract programs, like these are, imagine a program, NHS program, that can be anything. What about if we give people concrete examples? So we give an example of bowel cancer screening program where you send out a kit to people in the post, then it's up to them to pick up the kit and sort of, give you their sample. So it's kind of down to individual choice, individual responsibility. So we thought, let's do all different scenarios and see what we come up with. So I won't go through this because I already explained it. This is exactly the same framework, but we've changed the numbers here. The way we frame things. What we observed in the results is, so pro-rich are kind of at the extreme left and strict egalitarian are on the extreme right, so from my side. So what we see is that, there's quite a few interesting observations to make. So a huge proportion of our participants were strict egalitarians. They were willing to go all the way, to the extent that they were willing to take qualities away from the rich because inequality was being reduced, right? So this was quite an interesting thing, especially with the large average question. So we didn't find much of a difference, sort of statistical difference between large and small and population level framing of questions, but we did see some weak evidence of concrete versus other presentations. So if you were to talk about a concrete program, then people are less likely to be inequality averse or less inequality averse compared to an abstract program, because now they're thinking about whose responsibility it is. It's not NHS's fault. They're sending the kid out, So people start thinking differently. So I'm just trying to demonstrate the framing effects and cognitive biases. Online, we had a non-academic sample because we obviously advertise on academic forums, but also using our magazines and online forums and Facebook and stuff. So we were able to sort of then divide the online sample into non-academic and academic groups. Non-academics, again, sort of, a very different, well, not very different, but somewhat different distribution compared to this face-to-face group that we had. In the face-to-face group, there are obviously other potential biases. There's a group effect that may be at play. There may be a social pressure of because we had a little discussion, and then people filled out the questionnaire individually, but we allowed people to discuss beforehand. So there is a thing that you want to give the right answer. What is the right answer? There is obviously no right answer, but that social pressure may come into play. The academic group was very, very different from everyone else. Most of them were actually rated prioritarians, right? It could be because they are more used to seeing this kind of exercises. Maybe they understand this problem in a different way. I don't want to use the word better, but yeah. But what I'm trying to stress here is that depending on who you ask, how you ask, you may get different results. So elicitation of preferences is not an easy thing to do. If I'm allowed another couple of minutes, or 2-3 minutes, I can just quickly talk about the last part. So I'm sure you're familiar with Kahneman's work about fast thinking versus slow thinking. You give people questionnaires, they're not really thinking through this process because people want to respond. Generally, you don't actually give them a lot of time to think. So most of the time we are kind of slow. We are fast thinking. We are making decisions based on system 1, which is what Kahneman calls it, not in system 2, which is a slow thinking process. So we devised 2 slow thinking interventions. We thought, let's see if the slow thinking interventions have an effect on how people respond. So we developed a video animation where there were 5 people with 5 different views. We developed a script, and there were sort of cartoon animations with real people's voices, voiceovers, and they argued over different ideas, and they sort of each one was trying to advocate one particular view of inequality. And then the other one was we thought, rather than giving sort of these pairs, what if we give an interactive tool? Just give them a slider, and the slider, as you move the slider up and down, it actually tells you what level of trade-off you are making, right? What is the inequality gap at this time? What is the level of efficiency that you are giving up? So we developed these tools. So then this was the design of the study, 2 groups randomized, right? The first group, paper questionnaire, video animation, paper questionnaire. Second group, interactive questionnaire, video animation, interactive questionnaire. So this is what the video animation looked like. And this is what the interact. So these are all available to download on Center for Health Economics at the University of York website. So all the tools that we have presented are kind of available for use. These are the results, very interesting. So if we look at the paper group at the top, before we showed them the video, huge proportion of people who were egalitarian, strict egalitarians, which is very similar to what we observed in the other study. And after we showed them the video, there's a huge shift. Most people actually became weighted prioritarians, right? Interactive, there wasn't a big effect. There was a difference between pre-video paper and pre-video interactive. So interactive tools gave, based on that, people were giving different preferences. And so these 2 effects we clearly observed, and these are kind of presented in terms of cumulative distributions of responses as well. And the change in predicted probabilities based on ordinal regression, ordinal probability model. So after the video, in this particular group, the paper group, there was a huge shift towards the trader group, weighted prioritarian, and the people were moved from strict egalitarian to this group. So just the last couple of slides, I'll basically just, in fact, I'll skip this. I'll move to the last slide. So what we found in these studies was that, while standard methods have problems, and certainly using a slider has got a starting point bias, midpoint bias. If you're using a script or video animation, there are other biases. Who gets how many lines? Who comes in first? Who comes in last? There's recency effect. There's all kinds of potential problems which we have tried to at least acknowledge in the discussion of our papers. But these, what I was trying to demonstrate is that although it's very important to look at distributional cross-effectiveness analysis, getting the weights based on social value judgment is not an easy task. It's full of difficult problems, but progress is being made in the right direction. And we need to move away from just looking at averages. We need to look at the distribution. And we need to think about equity informative decision-making, not just focus on efficiency. I'm going to stop here, taking a lot of time, but any questions, I'm happy to take questions. Thank you. Yes.
A question, maybe some bit. We had an election here yesterday, as you know.
Yes.
And, this may be true in an experiment that people have inequality aversion, but I tend to say that people just voted in, very regressive, anti-taxation, anti-equality government.
Yeah.
So do you think this reflects how people act in the real world?
So this is exactly the question that we asked when we did the first study. We thought this is, this is unbelievable. To the extent that we thought there are certainly some biases going on. So I completely agree that if you the Atkinson Inequality Index that we got from our studies says that the implied weight associated with the poor group is 7 times roughly compared to the richest, which is significantly large. The interesting thing is that it's not very different from what some of the other studies have found. But yes, there is potential biases that are going on, and I'm not claiming at all, and we're not claiming at all in our papers that this is a true representation of what the public actually thinks.
So maybe going back to your thinking fast and slow, I think people vote thinking fast, given the kind of sloganeering we saw. Hijack this, I think it's great. But I think, I don't think people think through the issues as carefully when they vote as they do when you force them to look at these sliders and look at the consequences and make decisions. I think people spend less time than that when it comes to making a decision on.
That's interesting. So you think it's
I don't think people are thinking. Yeah.
Maybe.
So I tend to believe this. I think people generally, individually, are probably anti-inequality.
Yes.
But they respond to certain stimuli.
Yeah. And elections are obviously based on personalities as well. So there's a lot of that. It's more than. But fair point. Absolutely. Yes. Sorry. Yes.
Do you find that with the equity, it's more of an issue with? It's going to be difficult to explain. So, say you take a group of asthma patients. Are you more concerned with the equity within that group of asthma patients, or if you look at a more macro level, you have diseases which are obviously more prevalent in individuals from a lower socioeconomic background, such as obesity. So I suppose if you're doing an economic evaluation in asthma patients, you're like, oh, this has no impact on equity, that's absolutely fine. But actually that funding might be taken away from other conditions that would have a higher equity impact. So when you are looking at equity, do you kind of focus just on the disease, or is it kind of more?
So you could do both. And the thing is, the important thing to remember is that even if you're just looking at the asthma group, the treatment uptake rates, availability, those kind of things are not sort of, equal across areas. So interventions, most submissions that we review, equity is not an important aspect that is highlighted. But there are interventions in which, so for example, if you're looking at depression, psychotherapy, the uptake rate of psychotherapy is not going to be the same for the richest and the poorest quintile, just looking at a particular health condition, right? So I would basically advocate for looking at equity from both within disease area and also across disease areas in relation to where the resources are coming from. Yeah.
I'm wondering, have you experienced in presenting this type of information to decision makers, and what's their feedback? And I'm thinking more in terms of equity informed cost effectiveness analysis, where those. Yeah.
So the work that we have presented primarily is the decision makers in the NHS, but it's the performance management bit which we but not the economic evaluation bit. And I think in principle, equity weighted or equity informated economic evaluation is something which is part of most guidelines that are produced. NICE has equity in its in the technical guidelines. CADET certainly considers it, but it's not something which is part of submissions usually, and I think we are still a long way away, and that part of the reason is because the methods are not developed as well as the methods for cost effectiveness, standard cost effectiveness analysis. And I think what we're trying to push with this is that decision makers need to think about equity, but also think about making progress in operationalizing this and making it part of the decision-making process. It's not, and that's why one of the things that I always say is that we know people are inequality averse, but it's not enough to know that people care about inequality. We need to quantify, and therein lies the trouble. How do you quantify it? And what has not happened in the last few decades is enough money going into equity research. I think it has become more fashionable. It has become certainly, I'm sure, in Canada and most other sort of publicly funded. I can't speak for the US, but certainly for other countries, that is true.
Did you find similar studies in other countries?
Yes, so one of the papers that I mentioned is Spain. I think some of the European countries have done studies, and again, high levels of inequality aversion. People do care about inequality. Now the thing is, there is that recency effect as well, right? So when it's right in front of you, in front of you, in your face, you can't. There is that moral side of you that sort of becomes alive, probably. But then that is one of the issues with any sort of value elicitation exercise or preference elicitation exercise. There is that focusing illusion, right, or whatever other terms are used in this area. So, but yes, most studies have found that people are inequality averse to a surprising level. And when you start looking at the level of inequality aversion, you kind of think there are some biases in these studies. And that was the motivation for these studies, because we need to think about it's not a simple question of how would you allocate. It's much more difficult.
Do you think, you kind of touched on it, that the onus of equity issues kind of lie on the health economists? Because I kind of see health economics as like a component of the decision-making process. And I kind of see equity as like its own separate component. It's kind of like you have the health economics, which tells you what the efficiency gains are. And then you would almost have a separate component, which was what are the equity concerns? And whether we need a quantitative, I mean, at the moment, I don't think equity is particularly well looked at in decision-making processes anyway. I suppose, so the question is, do you think, should we be incorporating this quantitatively in our analysis, or should it be its own separate component whereby, like we discussed the clinical evidence, the health economics, the implementation concerns, the equity concerns?
Yeah. So I think, and you would probably agree with this, that the whole idea of cost effectiveness analysis that we look at is to inform decision making, and in that process we deliberately make sure that we don't ignore clinical evidence, and we're not accountants. We're not just looking at the cost side of things. The idea is to bring them together within one framework. So the point that we are trying to advocate in this is to bring equity within the same framework, rather than saying it would be nice to reduce inequalities because people care about inequalities. Thank you very much. And that will be a separate chapter. But what we're trying to say is that the same way as clinical evidence is all part of the decision-making process, and cost is part of the same decision-making process, inequality reduction should also be part of the same process, and rather than an appendix to a report.
You mentioned smoking cessation as something that may increase inequity, smoking cessation program.
The point I was trying to make was that depending on the intervention that we look at, some interventions are more likely to be taken up by certain quintiles of the population. So obviously smoking cessation interventions, you probably know more than me, goes from CBT to patches to chewing gums to any, So for some of the interventions are more likely to be taken up by the richest quintile. Psychotherapy may be an example.
Well, I asked because the hospital is thinking of implementing a smoking cessation program with inpatients, and I'd not really thought of this because that's a specific concrete example of an intervention, and you can see maybe people think, well, people smoke, if they're on choice to smoke, maybe they wouldn't be so willing to spend more time or money on the lower socioeconomic status smokers if they would if it's something that was a blameless kind of so I guess so my question is, in that for that concrete example, to make it less inequity inducing, you'd spend more on the patients you knew from disadvantaged areas. Is that the way you would modify the intervention so you wouldn't increase inequity?
So I think one of the ways of approaching this is to look at the evidence in terms of what intervention works better for which particular group. So some interventions probably work better for the poorest fifth. So making those available, and they may cost more, and approaching people from the lower socioeconomic background may cost more in terms of getting contact with them, trying to get in touch with them more times. But I think that's one of the things that any healthcare provider needs to think about. That so we do this meta-analysis and say CBT comes out to be the most effective intervention, and for smokers, and then we basically go with CBT. But what we need to look at is there a gradient in terms of effectiveness rate, in terms of uptake rate? Because what we may end up doing is offering CBT. On average, we may improve outcomes, 20% is smoking cessation rate. But what we've ignored is the gradient, and maybe it's the richest and probably the middle class are the ones who are taking up. So I think that is an important consideration for decision makers.
Do you have any? Have you done any studies or know any studies that kind of look at equity efficiency trade-offs? So experiments which actually ask people to say, okay, how much health would you be willing to trade off for a more equal distribution of health, or some questions.
So that's what we try to look at in the studies that I presented just now. That how many years of life are you willing to give up?
Yeah.
To reduce inequality? Yes. Yeah.
Did you kind of hit any kind of how could that be incorporated into kind of a threshold estimate? Would you weight quality differently?
So this framework of distributional cost effectiveness analysis, which I mentioned. So Nick Dalasaria wrote a paper in medical decision making where I think there's a tutorial on that as well, which explains basically the components that you need are these value sets. You also need initial distribution of health. You need all the other elements that you need for cost effectiveness analysis. And using all of those components, you can actually incorporate social value judgments into a distributional cost effectiveness analysis, which is basically an extension of the traditional cost effectiveness analysis, but it explicitly incorporates the social value judgments into decision making. And it may change decisions. It may change decisions, yes. Yeah.